Thank you everyone for joining for day 2 of the Neonatal Ventilation course. My name is Dr. Yasser Masood, and with me is Dr. Terry Cullen joining us from Melbourne. This is second day of the Neonatal Ventilation course. Yesterday we talked about non-invasive ventilation, we talked about CPAP and HFNC, and today's session is about conventional mechanical ventilation in neonates. So just a disclosure that the CME department, myself, Dr. Terry Cullen, and the faculty, we don't have any financial interest with any of the devices mentioned during the presentation. Few housekeeping things. Please keep yourself muted during the talk. If there are any questions, please type them in the question and answer box, and we'll answer them at the end of the session. So for today's session, the learning objectives are that we discuss indications of mechanical ventilation, like which are the clinical indications where the neonates need ventilation, what ventilator parameters we should be starting, and what are our goals of ventilation. Then we'll discuss different ventilation modes and how to act on poor oxygenation, over-oxygenation, over and under ventilation. And then we'll talk about weaning and extubation strategies. I'll give a couple of cases and then we'll discuss these cases at the end as well, that how we should be ventilating these babies. So the first case is a 30 weeks preterm baby with a birth weight of 1.5 kilograms, with no antenatal steroids given to the mother, and intubated in delivery room, given surfactant. What ventilation mode and settings will you choose? So this is our first case, and we'll discuss this at the end. The second case is a term baby with severe HIE due to a cord prolapse at the time of birth. The baby needed intubation due to very poor respiratory effort. After admission to the NICU, what ventilation settings you will choose and what ventilation mode you will use. And the third case is a term baby who's coming back from theater after repair for tracheoesophageal fistula and esophageal atresia. What ventilation mode and settings will you choose? So these are the three cases which we will discuss at the end of the session. So what are the indications of mechanical ventilation? The bread and butter our day-to-day is respiratory. So the commonest is respiratory distress syndrome in prematurity. That's one of the commonest reasons that we ventilate newborns. And other indications from a respiratory perspective are meconium aspiration, congenital pneumonia, persistent pulmonary hypertension of the newborn, congenital lung malformations like congenital diaphragmatic hernia. So these are the commonest indications from a respiratory point of view, but the commonest of respiratory is the respiratory distress syndrome. Then cardiovascular, so babies who have severe congenital heart disease, usually the duct-dependent lesions like hypoplastic left heart, or duct-dependent lesions like severe coarctation. If we are needing to give a high dose prostin, these babies might need mechanical ventilation. And then one of the biggest chunks, especially while working in Pakistan, is the babies with neonatal sepsis who need mechanical ventilatory support. And usually these babies, they need respiratory support because they are in multi-organ failure, which compromises not only the breathing, but it also affects the heart, it also affects other organs of the body. So sepsis is one of the commonest reasons for babies needing mechanical ventilation. Then metabolic, so the babies with a variety of inborn error of metabolism, if they're encephalopathic, they will need mechanical ventilation. Or if the babies are severely acidotic and it is not possible to correct the acidosis quickly, those babies need cardiovascular support and respiratory support until the underlying condition is managed and the baby is stabilized. And then another big group of babies who need mechanical ventilation is neurological. The commonest of these is hypoxic ischemic encephalopathy due to perinatal hypoxia and ischemia. So these are the babies who are compromised at the time of birth. They're encephalopathic and they're not breathing, so they need ventilatory support. Apart from hypoxic ischemic encephalopathy, there is another group of babies who might have central neurological disorders like congenital brain malformations of various types, which affect the baby's ability to breathe effectively, like congenital brain malformations like lissencephaly or other severe malformations. Those babies, they need respiratory support. And then another group of neurological disorders is where the babies are very, very floppy. So the classical example is spinomuscular atrophy or other severe congenital myopathies and neuropathies and muscular dystrophies. And these are the babies who are not breathing and they need respiratory support. So a very big group of neurological disorders where babies might need mechanical ventilation. And then surgical. So most of these babies are generally, if the surgery is being performed as an elective procedure, as I mentioned, tracheoesophageal fistula, congenital atresias of the bowels, so like ileal atresia, duodenal atresia, jejunal atresia, for congenital diaphragmatic hernia, tracheoesophageal fistula, imperfect anus. So a variety of surgical conditions. And when these babies, they go to theater, they usually need ventilation. And post-operatively, depending upon what kind of operation has been done, the babies may need ventilatory support for 24 to 48 hours. And that usually is mainly for pain relief reasons. So these are the group of disorders where the babies need mechanical ventilation. So when we are going to put a baby on the ventilator, there are certain questions that we want to ask ourselves. Not only just the why we are ventilating the baby, like what is the clinical indication for ventilating the baby, but on an individual basis, we also want to know that how are this baby's lungs? Are the lungs normal or are the lungs not normal? How is the heart? Is the heart functioning normal, or is the myocardial function or the heart function is impaired? How is the brain? Is the brain normal, or is there any evidence of encephalopathy, or is there any evidence of congenital brain malformation? Is there any intracranial hemorrhage or intraventricular hemorrhage? How are the kidneys? Is the baby passing urine? And how are the other organs like gut, liver? And how long the baby is expected to stay on the ventilator? So these are all different questions that we have to ask ourselves when we're putting the baby on the ventilator, because these are the questions which will help us in deciding that what ventilation mode and what ventilation settings we should be using when we start the baby on the ventilation. And as we go along during the period of mechanical ventilation, we still need to keep thinking of all these questions and then adjust our ventilation strategies based on answer to these questions, and also based on the blood gases and the clinical status of the patient. So as we speak, we have two choices in terms of the ventilation modes. We have pressure control ventilation modes and we have volume control ventilation modes. And I think as clinicians looking after babies on the ventilator, it's very important that we understand these ventilation modes very clearly, and in our heads, we are very clear that how these two ventilation modes work, because the ventilation strategies, the weaning strategies for both modes and the initial starting settings are very different. So if we decide that we are going to start the baby on the pressure control ventilation mode, what are the different parameters that we will need to set on the ventilator? And the first one would be peak inspiratory pressure, which is the maximum pressure generated during the inspiration. And usually for preterm babies, it's around 18 to 20, and for term babies is around 25 centimeters of water. The PEEP or peak end expiratory pressure is set around 4 to 6 centimeters of water. Most of the modern ventilators, we need to set only the I time. The IE ratio is generally not required in the modern ventilators. That is calculated by the ventilator in the background. So the I time is usually around 0.35 to 0.45 seconds as a starting. And the respiratory rate is set again, depending upon the individual patient condition, could be anywhere from 30 to 60, but that again depends on the individual patient. And the last is the FiO2. Again, usually when the babies are needing mechanical ventilation, most of the time the FiO2 is over 40%. So that is titrated up and down based on the individual patient's oxygen saturations. So these are the settings which we need to set if we're starting the patient on pressure control ventilation. However, if we're, so what happens in pressure control ventilation, that the peak inspiratory pressure which we set is fixed, so that won't change. But depending upon the lung compliance and underlying pathology, the tidal volume will keep changing. So that's why it's important that when we are using pressure control ventilation, when we have set PIP, we need to keep a very close eye on the how much tidal volume is the baby generating. So our aim is to achieve a tidal volume of around 4 to 6 mL per kilogram, or even higher if we are struggling with oxygenation or ventilation. So that's our aim, that we are achieving a tidal volume of 4 to 6 mL per kilogram. If we're using volume control ventilation, then the initial starting settings are different. And the settings that we need to set on in that case, the most important is that what is the target tidal volume that we want to deliver, that we want the ventilator to deliver to the baby. And the target tidal volume, as I mentioned, is anywhere from 4 to 6 mL per kilogram, could be higher if you're struggling with oxygenation. On volume control ventilation, we do not set the peak inspiratory pressure because that will vary depending upon the individual lung compliance with each breath. However, as a safety parameter, in all the ventilators, there is a thing called P max, which means that if the ventilator will not go beyond this P max. So in most ventilators, this is usually set at 30 centimeters of water, which means that if the ventilator is needing to go above 30 centimeter water to deliver the target tidal volume, it will start alarming that the Pmax is reached. And at that point, then you need to think that why the baby is needing such a high pressure. There might be some mechanical issues, like there might be that the tube is obstructed, or there might be that the lungs are so stiff that the ventilator is needing a higher pressure. Just like pressure control ventilation, the PEP is set around 4 to 6 centimeters of water, and the I time is 0.35 to 0.45. And the respiratory rate is again anywhere from 30 to 60 based on the individual patient. So these are the settings that we set if we are using volume control ventilation. And the FiO2, as I said, based on the individual patient saturation, that is titrated up and down to target saturations above 94%. So what happens in volume control ventilation is that we tell the ventilator that this is the tidal volume I want you to deliver with each breath. And then the ventilator will decide after each breath that how much pressure it needs to deliver that tidal volume. And that pressure will vary with each breath, especially in babies who are preterm and RDS and are given surfactant. The lung compliance tends to improve very quickly after giving surfactant. So we will see that on a certain target volume, the PIP generated will gradually start coming down on its own. And that's the beauty of using volume control ventilation, that there is auto winning of the peak inspiratory pressure as the lung compliance improves. And it's very important that we keep a very close eye on PIP generated and adjust the tidal volume based on gases, FiO2, and the clinical condition. As the PIP is coming down, that means the lung compliance is improving, the FiO2 should come down, the gases should get better. We can wean the tidal volume. If we're using 5 or 6 mL per kilogram, we can reduce that to 4 mL per kilogram. Once the patient is on minimal tidal volume with good gases, minimal FiO2, and minimal peak inspiratory pressure, at that point, we can consider extubation. So these are the two different ventilation strategies: pressure control ventilation and volume control ventilation. So the question that we want to ask when we putting the babies on the mechanical ventilator is that what are our goals, what we want to achieve. Basically, that only two goals. We want to oxygenate the baby. We want good preductal saturations, ideally above 94%. And the second goal is that we want to clear the CO2. We want the CO2 in the normal or in the slightly higher range. So these are the two goals of mechanical ventilation. For the baby might be on the ventilator for whatever indication, whatever the organ dysfunction, but the goals are only two. We want to oxygenate the baby and we want to clear the CO2. So these are the only two goals. So what affects the oxygenation and how we can improve the oxygenation? The first is obviously FiO2, that can be anywhere from air to 100%, depending upon the individual patient. And the second most important thing which determines the oxygenation is the mean airway pressure. Now, the mean airway pressure is calculated by the ventilator. It's a very complex formula which we don't need to remember, but on a diagrammatic basis, you can see that a mean airway pressure is basically, if you look at this diagram, is area under the curve. So you can see that this black solid line, and so that's peak inspiratory pressure. It goes up and down, and then so the area under the curve is our mean airway pressure. And if we want to increase the MAP, what we want to do is we want to increase the area under the pressure. And what we can do that by doing different things. We can increase the rate of rise of peak inspiratory pressure by reducing the slope or increasing the gas flow rate. The gas flow rate is usually around 6 to 10 liters. So if the gas flow rate on the ventilator is around 6 liters, you can increase that to 8 liters or 10 liters. We can increase the PIP, or we can increase the I time. We can increase the PEEP, or we can increase the rate. So all these things, what they will do is they will move this black solid line. They will move these things upwards and ultimately increase the area under the curve, and that will increase our mean airway pressure. So when we mechanically ventilate newborn babies, usually the mean airway pressure that they're needing is anywhere from 12 to 15 up to 18. So it's a variable number depending upon the individual patient condition. But if we're struggling with oxygenation, then the two things that we can do to improve the oxygenation is adjust FiO2 and increase the MAP. And to increase the MAP, there's not a single knob that we can turn up on the conventional mechanical ventilation to increase the MAP, but we can increase the MAP by doing one of these things that we have mentioned. And this is a very important concept to understand, because most of the time when the babies are on the ventilator, oxygenation is an issue. And to improve the oxygenation, one have to understand that the mean airway pressure is very important parameter which determines the oxygenation, and what are the different things that we can do which will increase the MAP and increase the oxygenation. And when we will talk about high frequency ventilation tomorrow, you will see that this is a very important concept again in high frequency ventilation as well. And then the second goal after oxygenation is that at the same time we want to ventilate the baby, we want a good CO2 clearance. For preterm babies, we tend to tolerate a slightly higher CO2, but for term babies, we aim for normal CO2. And the ventilation is determined by what we call is minute ventilation, basically. So minute ventilation is the respiratory rate times the tidal volume. So these are the two different things which we can adjust to improve the ventilation. If the CO2 is high, we can either increase the respiratory rate if we can, or we can increase the tidal volume. And to increase the tidal volume, if we are using pressure control ventilation, we can increase the tidal volume by increasing the peak inspiratory pressure. And if we're using the volume guarantee ventilation or volume control ventilation, then we can increase the target tidal volume. So by increasing one of these two parameters, tidal volume and respiratory rate, we will increase the minute ventilation, and that will improve the CO2 clearance. So, so coming on to what are the different modes of ventilation that we can use. On the left, on this side of the screen are the pressure control mode, which are SIMV, which is synchronized intermittent mandatory ventilation. The second one is assist control, and on different ventilators, the other names for the same mode are SIPPV or PTV. And the third mode is pressure support ventilation. So these are all different kind of modes which we can use in pressure control ventilation. And we can use all these modes on its own, which is pressure control ventilation, but we can also use these with volume guarantee. In that case, this will become volume control ventilation. And in all the modern ventilators now, there's an option to use volume guarantee ventilation along with all these modes. So how the SIMV works. So SIMV is synchronized intermittent mandatory ventilation, which means that this is patient triggered, and all the breaths which baby is taking will be synchronized with the ventilator breaths. There will be a set rate, which can be anywhere from 30 to 60. So the ventilator will deliver all those breaths. And if the baby has got good respiratory effort and is breathing above that rate, then all those extra breaths, they will be unsported. So that's the very important concept to understand, that on SMV, whatever rate we set, only those breaths will be sported by the ventilator. the remaining breaths which are above the set rate, they will be unsported. Therefore, it's important that if in SIMV, we should try not to use very low rate and not to leave the babies on low rate for a long time, because if we leave the baby on a very low rate, say for example on a rate of 10 or 15 or 20 for a long time, if the baby is breathing at a rate of 40 to 60, all the extra breaths above this number are being unsported, and it's very difficult for babies to breathe through the endotracheal tube unsported for long periods. So that's how the SIMV works. And the second mode, which is now the most commonly used modes in most of the NICUs, is called assist control on tracheal ventilators, and on other ventilators like Siemens and SLE, it's called SIPPV or PTV. The concept is basically that unlike SIMV, on this mode, all the breaths are sported. So that's the most important difference, that all the breaths will be sported. We will set a respiratory rate, which could be again anywhere from 30 to 60. But if the baby is breathing above that set rate, then even those breaths will be sported as well. So the set rate might be 30, the baby might be breathing at a rate of 60. So the ventilator will sport all those 60 breaths. So that's the difference, and that's why the assist control is more popular than SIMV, because all the breaths which baby is taking are sported. So on this screen, you can see at the bottom is SIMV, and you can see that only certain number of breaths are being sported. So these the dotted lines are baby's own breaths, and you can see that the baby's own breaths are unsported because they probably are above the set rate. And these are the ventilator sported breaths. But if you look at the assist control mode, this one, each breath where the baby is trying to take a breath, each breath is being sported by the ventilator. So that's the key difference between the assist control and SIMV, that on assist control, all the breaths will be sported, and on SIMV, only certain number of breaths will be sported. We don't use IMV mode on its own very much, and don't use control mode on its own very much. The commonly used modes are assist control and SIMV, and you can see there is a clear difference between these two modes. And it's important to understand, if people are using both modes, that what is the difference in terms of the sport for each breath. And then the third mode, which again usually either used on its own or commonly used along with SIMV, is pressure support ventilation mode. And on pressure control, the PSV is slightly different from both SIMV and assist control, in that instead of being time cycled, this is flow cycled ventilation mode, where once the gas flow has reached at a maximum, that's the phase one, where the peak inspiratory pressure is reached. And once the flow is down to 15% of the maximum flow, that's where the inspiration will end and the expiration will start. This ventilation mode is the patient will decide its own I time, the patient will decide its own E time, the patient will decide its own rate. So unlike SIMV, where we set as I time or IE ratio, on this ventilator mode, we only set what pressure we want, and the rest of the things are decided by the baby itself. So there's a lot of liberty for the baby to breathe how he or she wants to breathe. Moving on from pressure control ventilation to volume guarantee ventilation. So how the volume guarantee ventilation works. So on this graph, you can see that, as I mentioned before, that on volume guarantee ventilation, we tell the ventilator that this is the tidal volume that they want you to deliver. And then based on the lung compliance, the machine will decide how much peak inspiratory pressure it wants to deliver. So on the bottom, we have set tidal volume, which is usually around 4 to 6 mL per kilogram. So that is set by us. And then the machine will decide how much pressure it wants to give. And that PIP might vary with each breath. And this top line at this one, as I mentioned before, is the safety mechanism in the ventilator, that this is the maximum pressure that the ventilator will deliver. If the ventilator is needing to give a higher pressure than this line, then it will start alarming. So you have to go and see the baby and see the ventilator and see why the baby is needing such a high pressure. But otherwise, the peak inspiratory pressure generated will be variable with each breath, depending upon the lung compliance. If the lung compliance is improving, for example, if you've given surfactant, then peak inspiratory pressure will slowly start to come down. But if for some reason the lung compliance is getting worse, or if the lung condition is getting worse, like for example in meconium aspiration or in other conditions, if the lungs are getting stiffer, then the peak inspiratory pressure will continue to rise. So now we have pretty good evidence that volume targeted ventilation is better than pressure control ventilation, especially in preterm babies. This is the systematic review and meta-analysis from Australia. And they showed that between the two groups, volume targeted ventilation versus pressure limited ventilation, there was a reduced rate of death, reduced PPD, reduced pneumothorax, and reduced incidence of PVL and grade 3 and grade 4 IVH. It's becoming more and more in practice now over the last 5 to 10 years, but there's some reluctancy in using volume targeted ventilation, and probably a commonest reason for not using it is people are more used to using pressure control ventilation and they don't want to change, and also probably lack of experience and lack of knowledge as well to use volume targeted ventilation. Another important thing if you're using volume targeted ventilation is that the ventilators have to have very good flow sensors, because with each breath the ventilator is measuring how much target volume was delivered in the last breath. And if the flow sensors are not very good, then the volume targeted ventilation will not work. So the question we want to ask ourselves is what is more dangerous, whether we should be controlling the volume or whether we should be using the pressure. And the evidence is fairly clear that the volume is more dangerous. If you have got two sets of lungs, one is strapped somehow and the other one is unstrapped, and we give the same amount of pressure, there's clear evidence from experiments on the animals that the lungs which are strapped, where there's a certain amount of volume will be delivered, and not more than that. If you deliver the same amount of pressure to both the lungs which are strapped will be protected from lung injury compared to the lungs which are unstrapped. So clearly volume is more dangerous. That's why it's makes sense to control the volume rather than the pressure. So when we ventilate the babies, we want to ventilate the lungs with appropriate tidal volume, and on pressure control ventilation, the tidal volume continues to fluctuate due to baby's breathing effort, due to change in the compliance, ETT leak, and all those things. But if you're using volume control ventilation, then that variability of the tidal volume delivery is reduced, and that it also leads to less variations in the minute volume and more stable PCO2 and less incidences of hypocarbia, which we might see with pressure control ventilation, and it's less influenced by the ETT leak. So why we should be using volume targeted ventilation? As we saw, that reduces death, reduces the rates of bronchopulmonary dysplasia, reduces pneumothorax, reduces events of hypocarbia, reduces the duration of ventilation, and reduces severe cranial ultrasound abnormalities like IVH and PVL. So it's a logical strategy to use the tidal volume rather than peak inspiratory pressure. However, there are certain conditions where the volume guarantee ventilation will not work. If there's a significant ETT leak for some reason, if the ETT is very small, like for example, if the babies have a very small ETT, sometimes we see that the volume guarantee ventilation doesn't work because the ventilator cannot accurately measure the tidal volume, and if there's water in the circuit. So these are the conditions where we will see that the volume guarantee ventilation will not work. And what you will see on the ventilator in these cases is that on a certain set tidal volume, the peak inspiratory pressure, there will be very wide fluctuations. On one breath, there might be a PIP of say, for example, 10 or 12, and on the next breath, the PIP generated might be 20 or 30. So when there are wide fluctuations in the peak inspiratory pressure, that means that the volume guarantee ventilation is not working. So in summary, the assist control and SMB, these are the time cycled pressure limited modes. And if we add volume guarantee, then these modes will become volume control modes. The PSV is different from SMV and assist control. It is not time cycled, it is flow cycled, pressure limited. And if we add volume guarantee, then it becomes volume control ventilation. So essentially, you can use volume guarantee with any of the modes. And the most important thing for people who are learning to mechanically ventilate the babies is that if you're using pressure control ventilation, monitor your tidal volumes. You need to see what tidal volume you're generating. And if you're using volume control ventilation, then monitor your peak inspirated pressures to see how much pressure, how much PIP you are generating. Um, what is being done now in the modern NICUs in the world? So the commonest mode, which is used in the UK and in Australia, where Terry works now as well, is the commonest, the first line of choice is assist control or SIPP or PTV on different ventilators with volume guarantees. So that's the first line, first choice of mechanical ventilation mode. We can also use SMV with or without pressure support ventilation with volume guarantee as a weaning mode, especially for babies who have been on the ventilator for a long time, or the babies who have failed extubation before. And we want to see that these babies will be able to manage on their own off the ventilator. We can use SMV for a brief period with a low backup rate, with or without PSV. And if the babies are stable on low backup rate with good gases, low FiO2, and then that means that the extubation is more likely to be successful. However, as we discussed yesterday as well, that overall these days we're doing everything we can to avoid mechanical ventilation and manage babies with non-invasive ventilation. So what are our target blood gas values when we are ventilating the babies? The pH is, and the target pH that we aim is above 7.20 to 7.30. So especially for very preterm babies, excuse me, we don't aim for a normal pH. For the first few days, the pH above 7.20 is acceptable, and after first 5 days, pH above 7.25 is acceptable. And the PCO2 is acceptable between 5 to 8 kilopascals. And again, for preterm babies, and especially the ones who have got established chronic lung disease, we tend to accept even higher PCO2 as long as the pH is maintained. The PO2 is between 8 to 10, and the base excess is acceptable up to -4. Before you go and touch the ventilator, and if you need to look at the blood gas very carefully, that what is the primary abnormality on the blood gas. Look at the baby, is the chest moving? Does the baby need suction? Look at the ventilator, look at the graphs, look at the volumes which are being generated, look at the peak inspiratory pressure. And if there are wide fluctuations in different parameters, that means there might be something wrong with the equipment rather than the baby. And look at the nursing chart, that how long ago the suction was done. Does the baby need suction? So before adjust anything on the ventilator and touch any knob, we should be looking at all these things carefully, and only then adjust any of the ventilation parameters. If we're in terms of changing the ventilation settings, if the problem is low oxygenation or low PO2, that as we discussed, the things that we can do is we can either increase the FiO2 or we can increase the mean airway pressure. And to increase the mean airway pressure on the mechanical ventilation, we can either increase the PIP, we can increase the I time, we can increase the PEEP, we can increase the rate. As we discussed, all these things will ultimately increase the mean airway pressure, and that will improve the oxygenation. If the problem is high oxygenation or high PO2 and high saturations, then we need to come down on these two things. We need to reduce the FiO2 and we need to reduce the mean airway pressure, which we can do by reducing the PIP, as I mentioned, reducing the PEEP, reducing the rate, reducing the I time, or if you're using volume guarantee ventilation, we can reduce the target tidal volume. And it's important to mention that especially for preterm babies, we now have a very clear evidence that we should be not targeting higher preductal saturation in those babies. We should be targeting lower saturations because of the risk of retinopathy of prematurity, which is 90 to 94%. If the problem is underventilation with the high PCO2, then as I discussed before, that we need to increase the minute ventilation. To increase the minute ventilation, we can either increase the rate or we can increase the tidal volume. So increasing the rate is fairly easy. We can increase the backup rate, but to increase the tidal volume, if we're using volume guarantee ventilation, we can just increase the target tidal volume. But if we are using pressure control ventilation, then to increase the tidal volume, we can increase the peak inspiratory pressure or I time or PEEP, as I mentioned before, and all these things will improve the tidal volume. If the patient is overventilated with the low PCO2 and high pH, then we need to come down on the minute ventilation, which means that we need to come down on the rate and we need to come down on the tidal volume. If we're using volume guarantee ventilation, we can reduce the target tidal volume. And if we're using pressure control ventilation, we can reduce the tidal volume by coming down on the peak inspiratory pressure primarily. When you should be doing the next blood gas, again, that depends upon the individual patient condition and the blood gas itself. There's no clear-cut answer, but if the blood gas is really bad, like for example, if the pH is less than 7 or less than 7.1, or if the pH is very high, like more than 7.5, then you should be doing something fairly quickly and repeat the blood gas in about 30 to 60 minutes. But if the blood gas is fairly stable, the baby is stable, and no other parameters have changed significantly, you might want to do a blood gas in 4 to 6 hours times. So there's no set rule. It depends upon the individual patient condition and depends upon the individual blood gas. If the baby is deteriorating on the ventilator, this is a fairly commonly used mnemonic, which is DOPE. So either dislodgement, obstruction, pneumothorax, equipment failure. So if you're struggling with any baby on the ventilator, either oxygenation or ventilation, these are the things that we should be looking at and address those things. Finally, moving on to the weaning and extubation. As I said, the weaning and depends upon what ventilation mode and what ventilation strategies you're using. If you're using volume guarantee ventilation, then the weaning is usually done by reducing the target tidal volume, reducing the FiO2 gradually, and on the pressure on the assist control mode. Usually, because all the breaths are being supported, weaning the rate doesn't really help with weaning. But by weaning the target tidal volume and by reducing the FiO2, once the baby is stable on low volume, low FiO2, gases are good, you can extubate. On SIMV, as I mentioned before, that we should not be using low backup rates for a long time. And as soon as we know that the baby has got good respiratory effort, the baby can be extubated, provided the gases are acceptable and the FiO2 is less than 30%. So coming back to the 3 cases that I mentioned before, the first case, as I mentioned before, was a 30-weeker. I think we'll discuss these when we discuss the cases as well. But in this case, as I mentioned, my ventilation mode of choice would be assist control mode or PTV mode with volume guarantee, because we've given a surfactant to this baby, and the lung compliance is going to improve fairly quickly. So volume guarantee ventilation with assist control mode will be the mode of choice in this patient. The second case, in this case, I'm expecting that the lungs are likely to be normal. So the baby should not need significant amount of ventilatory support. The baby has needed a mechanical ventilation because of HIE and due to pure respiratory effort. So the lungs will be normal. So again, in this case, volume guarantee ventilation should be used so that we can control the CO2 in the normal range. So again, assist control or SIPPV would be the mode of choice along with volume guarantee ventilation. But you can also use, if you're not used to use assist control ventilation, you can also use SMV in this case as well. And third case again is the baby who's coming back from theater after surgery. And this baby again is likely to have completely normal lungs and will not be on the ventilator for a long time, probably 24 to 48 hours. So you could either use assist control or SMV with volume guarantee. That brings us to the end of the talk, and I'll ask Dr. Terry Cullen to facilitate any questions that we might have. Thank you.
Thank you. So if you could kindly type any questions that you may have into the question and answer box. We have a number here already. Tathir Zara says, will you send these slides also so we can review them afterwards? Is that something that we'll do?
Yes, we can send the slides afterwards.
Yeah. Namra Majid says, can you tell us how we would differentiate whether we should use pressure control or volume control ventilation? And is there a specific indication for that?
So as I mentioned, Namra, before that, currently the mode of choice is volume control ventilation. And we should try to use volume guarantee ventilation in every baby if we can. But as I mentioned, there are some patients who will not like volume guarantee ventilation, and it may not work for them. So in those babies, for example, if there's a significant leak around the ETT, if the babies are very small, they may not like the volume targeted ventilation. So primarily our efforts should be to use volume guarantee ventilation as a first mode of choice. But if we think that that doesn't work, or if in the unit that you're working at the moment, if they're not used to use volume guarantee ventilation, then you can use pressure control ventilation. But as I said, majority of our neonatal population are now being started on volume guarantee ventilation as a first choice.
Dr. Hassan Zulfikar says, how does the ventilator compensate for leak with uncuffed tubes? Should we be using cuffed tubes?
So the evidence for using cuffed tubes in neonates is very low, especially because of the risk of subglottic stenosis in preterm babies who were on the ventilator for a long time. So we have always used uncuffed tubes in our neonatal population.
Yeah, there are some articles coming through, particularly from surgical centres, suggesting that they are safe, but many ventilators have an inbuilt mechanism to compensate for leak anyway. So it's not really that necessary from our neonatal perspective. We've got a comment here from Dr. Malik. Please elaborate on the 2-minute breathing test for weaning as it's used in adult ventilation and use of parameters like P 0.1 and plate pressures. I'm not sure what's meant by.
So I don't think that we use any such thing for testing whether the baby's extubation will be successful or not. Yeah. As I said, we will keep the baby on the ventilator, and we will use a low backup rate on SMV for a few hours and see whether the baby can cope. But that again depends on the individual patient condition. There might be some babies, like surgical babies, who might not need this test because we know that they've got normal lungs and they are extubated fairly quickly, even sometimes from higher settings. So I think that we don't use this test in neonatal population. And the strategy for weaning and extubation is there's no single strategy. It has to be decided based on the individual patient, individual pathology, and for how long the baby has been on the ventilator, and has there been any previous extubation failures or not.
Yeah, I think occasionally if you're worried that a child might not be successful, you might put them on a CPAP setting for a minute or so just to check their respiratory drive is still there. But there is evidence that putting children on endotracheal delivered CPAP is actually detrimental if you're looking to extubate them. So you wouldn't do that for any prolonged period of time.
I think you're very right. I've seen some people using ET CPAP to test whether the baby can successfully extubate or not. But that practice, again, there's no evidence to support that practice. So I think that practice should be discussed.
We have a question here. What is the normal neonatal tidal volume range in terms of the minimum and maximum settings? As you said, so it's
4 to 6 mL per kilogram. But if you're struggling with oxygenation, you can go up to 7 to 8. But 4 to 6 mL per kilogram is a standard range for target tidal volume.
Yeah. The next question here is, can you tell us about the use of sedation in a struggling baby?
So I think that we have to ask first ourselves that why the baby is struggling, what is the reason that the baby is struggling. But the sedation we do use, especially in term babies who are likely to be on the ventilator for more than say 24, 48 hours. We do use sedation, and different units have different sedation strategies. In Manchester, we used to use morphine and midazolam. Here we use fentanyl and midazolam. And sometimes if the baby is really, really sick, for example, babies with severe PPHN, we sometimes even paralyze them. So those things like sedation, paralysis, they all depend upon the individual patient condition. When you say struggling, we need to know exactly why the baby is struggling. Where is the problem?
I mean, are the child demonstrating air hunger, and in fact, does their ventilation need to be optimized potentially? Tell us about your experience of the use of end-tidal CO2 and what is target. So we've used a fair bit of end-tidal CO2 in Australia, particularly with the neonatal transport team. And the use is very different from pediatric and adult medicine, where you would have an end-tidal CO2 and target numbers. With neonates, the difficulty is because of the varying sizes of the baby, the number is less reliable than the trend, for example. And the main use of end-tidal CO2 is to tell you about the risk of, for example, tube dislodgement, because that will give you that feedback immediately, whereas without some sort of feedback from either ventilator, that information might be missing. It may take you a little while to work through the algorithm to realize the tube is in fact displaced. Dr. Iqbal asks you to bring up the slide with the mean airway pressure mathematical equation.
So I think we have already discussed that in our presentation. I don't think you need to remember that equation. We'll share that on the slides as well. But yeah. What we need to remember is to increase area under the curve, as I mentioned.
Yeah. Dr. Usman asks, in case 1, you have a baby that's 1.5 kilos, and the ET tube size is almost 2.5. Why should we not choose pressure control?
So it depends why you're ventilating this patient. As I said before, if you're ventilating this baby for RDS and you're given the surfactant, the lung compliance is going to improve pretty quickly. And if you use pressure control ventilation, you might give much more volume and it might cause value trauma. That's why it's important to control the volume and use volume guided ventilation.
Yeah. Can we simultaneously increase our oxygen saturations and our CO2? And how?
So we can increase the oxygen saturations by either increasing the FiO2 or by increasing the mean airway pressure. But when you say simultaneously increase the CO2 will only increase if your minute ventilation has gone down. So your minute ventilation will go down if your rate is very low or if your tidal volume is very low. So both are very different. So the different strategies to adjust these two parameters.
An attendee asks, what is the main difference between pressure control and volume control? In which condition will we select these? Well, I think in the whole focus.
I think I've talked in detail about what is the difference between two modes. So I've discussed that in the presentation.
Yeah, I think so. Why haven't you mentioned CMV mode? As in some post-surgical conditions, you need to sedate the baby, as in congenital diaphragmatic hernias, to avoid post-surgical complications.
So I have not discussed CMV intentionally because if you're using a paralysis and your baby is completely paralyzed, whether you're using SMV or whether you're using assist control mode, they essentially become CMV mode. So CMV mode on its own is not used anymore. No. And even in those babies who are paralyzed post-operatively, for example, as you mentioned, whether you're using SMV or assist control, once you paralyze them, then that becomes CMV.
Yeah, and I think really there is no place for CMV in this day and age, because once that child starts to breathe themselves, you will want a ventilator that is synchronized to their breathing to minimize the risk of complications of valvular trauma, barotrauma, pneumothorax. And so, as he said, if the child is not breathing, then all of the synchronized modes in an apneic child will deliver CMV, but you want a mode that can synchronize with the child when they start to breathe for themselves. Which drugs should be used for paralysis and sedation? As you said, that may vary from hospital to hospital.
Variety of drugs, different units, different policies. In Manchester, we use fentanyl for sedation and succinylcholine for paralysis, but some units use morphine for pain relief and atracurium for paralysis. So it depends upon, there's no set standard in different units. Different units use different medicines. But the more important thing is any baby who needs intubation should be sedated and should be paralyzed. Awake intubation in 2021 should not be done. You agree, Terry?
Oh, it'd be traumatic. It'd be torture. Imagine if someone would try and do that to you. You would not enjoy it at all, and you run the risk of intraventricular hemorrhages and trauma to the vocal cords. You want that child asleep, comfortable, and it's hard to intubate a moving target. Yeah. And an attendee asked, I missed yesterday's session due to technical issues. How do I access that?
So our CME department will share the recording afterwards.
Very good. What should be the settings of the IE ratio during mechanical ventilation in neonates?
So it's anywhere from 1 to 1.5 to 1 to 2. But as I said, on modern ventilators these days, generally you will set the I time and the respiratory rate, and the IE ratio is usually not displayed on the ventilator. That's calculated in the background. Yeah. But if you're to ask for the ratio, it's anywhere from 1 to 1.5 to 1 to 2.
Yeah. What should be the maximum and minimum values of the PIP and PEEP and I time?
So for PIP, again, there's no really maximum, because if the baby needs more peak inspiratory pressure, you have to give it. But obviously, after a certain pressure, you need to start thinking of other modalities. Say, for example, a term baby. Once you reach a PIP of 30 or 35, then you need to start thinking of high frequency ventilation. In terms of the lower minimum for PIP, I would say that even for preterm babies, shouldn't be really ventilating below 14 or 15. Once your PIP is down to 14 to 15, you should be thinking of extubation. For PEEP, the range is from 4 to 6, but sometimes in babies, for example, with pulmonary hemorrhage, might need to go up on the PEEP up to 7 or 8. And for I time, the range is between 0.35 to 0.45. But in struggling babies with oxygenation, we might need to go up to 0.5 or even 0.6 in some cases as well.
If we don't have ABGs initially, blood gases initially, what should be the initial settings for starting a baby on AC mode of ventilation?
Yeah, so for preterm baby, as I mentioned in my presentation, for a preterm baby, you could start with for 16 to 18/5. And if you're using volume guarantee ventilation, you will start with anywhere from around 5 mL per kilogram of tidal volume.
Do we routinely paralyze and sedate neonates on mechanical ventilation? As you said,
No, we don't.
We would paralyze and sedate to intubate, but your goal after that should be extubation. So you want their respiratory drive up and you want them awake, ideally, but it depends on their pathology. A 1 kilo preterm baby given surfactant and attached to the ventilator, which during period, I'm not going to answer that. I'm not sure that's what the question is there. If the baby's been intubated twice, can we intubate the third time?
If the baby needs intubation, yes. Yeah, it depends. I don't understand this question either. If the baby needs intubation, needs to be intubated.
Yeah, and you think long and hard before extubating them.
Yeah, we'll take a couple of more questions, and if the remaining questions, if the kindly participants could email us, and then we can answer those questions through the email. We'll take 2 more questions.
In primary lung pathology such as pneumonias, is volume generated ventilation preferred?
Yes, as I said, for any baby, the volume targeted ventilation is the preferred mode, even if it's pneumonia or bronchiolitis or whatever. Yes.
Yeah. Can the ventilators deliver volumes below 20 mils? Anesthesia workstations have a ceiling on the lowest volume being 20 mils.
Sorry, what's the question again, Terry?
Can the ventilators deliver volumes below 20 mils?
Yes, yeah. Like if you've got a 1 kilogram baby, the tidal volume for that baby will only be 5 to 6 mLs per kilogram. So the ventilators will deliver that volume. Yes. So that's the whole idea of volume guarantee ventilation.
Which mode is preferred if there's a small leak, if there's a leak due to a small ET tube?
So if you have got a leak of anything more than 30%, then the volume guarantee ventilation will not work. Yeah. So in those babies, you should either use pressure control ventilation or you should try to upsize the tube if you can.
Yeah. I have a patient on PCM mode ventilator with lung compromise, a high CO2, about 60 to 90. I increase the rate and the PIP, but the CO2 does not decrease. Are there any other ways to decrease the CO2, or should I change the mode?
Which mode are they using, Terry?
It says PCM. Pressure control mode ventilator.
Yeah, if you're using pressure control ventilation and the CO2 is high, you need to increase your alveolar ventilation. As I mentioned, to increase the alveolar ventilation, you can increase the rate, you can maximize the rate, and you can increase the tidal volume by increasing the PIP, by increasing the I time, by increasing the PEEP. And if you're still struggling with CO2 clearance on conventional mechanical ventilation, then you might need a high frequency ventilation. Yeah. So we'll take 1 more question, Terry, after this.
What are the protocols immediately after extubation?
Again, that depends upon the patient. All preterm babies after extubation should be started on CPAP. That's standard. There's no doubt about that. For term babies, again, depends why they were ventilated. What was the reason for ventilation? If it was like a surgical baby who needed ventilation only for surgery, they probably don't need any respiratory support. But if the ventilation was for a respiratory reason like meconium aspiration or PPHN, then they might need a step down non-invasive ventilation, which could either be CPAP or high flow, as we discussed yesterday.
All right.
Okay. Thank you, Terry. I think we're very grateful for interesting questions from the participants, but it's difficult to answer all those questions. So if any more questions, if you could kindly email us, we can answer those questions on email. And thank you, Terry, for your help today. Tomorrow's last day, and we will be discussing high frequency ventilation tomorrow. So look forward to seeing you all tomorrow. Thank you very much. Thank you.